Welcome to the Sonosite webinar on diagnostic shoulder exams, the posterior shoulder. With us today, we have Daniel Shelton. Daniel Shelton is the Director of Musculoskeletal Market Development for FUJIFILM Sonosite. Daniel spent 16 years as a dedicated musculoskeletal sonographer, and 10 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. With that, Daniel, I'll turn it over to you to get us started.
Thank you for that introduction, Laura, and we'll go ahead and continue with the presentation. Again, my name is Daniel Shelton, and this is the third of a four-part series for the full diagnostic shoulder. Join us next time also for the superior shoulder, and any Q&A will be answered live also. Today we're gonna discuss the posterior shoulder, specific to the infraspinatus and the Teres minor. And we're also going to take a glance at the posterior labrum and what can be visualized there, and the spinoglenoid notch. Just a little bit about the anatomy in the posterior shoulder. Specific to infraspinatus is the origin being over this infraspinatus fossa of the scapula. Good palpation landmark, which we'll go over live, is the acromion process here posteriorly, and then the spine of the scapula. Basically, you're going to set your probe right under this posterior corner of the acromion. We have highlighted here how lateral this tendon goes when we're in a neutral position, which is what we're going to be scanning. And then we'll internally rotate the shoulder when we're scanning live with the patient's arm across their belly, and you'll see that this greater tuberosity travels very lateral. Here are the image differences between the more proximal over the glenohumeral joint, and then when we follow the tendon out laterally to its enthesis, what we actually get. So over the glenohumeral joint, we get this big comet-tailed shaped infraspinatus with a central tendon and surrounding muscle. It's a multi-pinnate muscle, and so the central tendon looks really nice because there's a little bit of muscle on top. Down below, we have the cortical landmark of the humeral head, and then the greater tuberosity's middle facet back here, more posterior. Here's the glenoid labrum, the posterior glenoid labrum. And then there's a joint capsule that's really, really thin right here, stretches from the superficial surface of the posterior glenoid labrum over and then underneath the infraspinatus. And then when we do our rotations, which we'll show live, you can actually see that joint capsule when you externally rotate and then when you internally rotate. And then back here, a little less clearly seen, is the spinoglenoid notch. And I think it's just better described in the live imaging. So we will go over the scanning technique for that to further clarify the anatomy. One pitfall when you're scanning the distal infraspinatus tendon, as that tendon wraps around, you may get this dark shadow in the center of the tendon, and very, very commonly you're going to be scanning under this little deltoid septation here. So this connective tissue here can lay down kind of an edge artifact on each of its sides, or just the sheer change in density going from a fluid-filled muscle on both sides to relatively less than fluid-filled densely connective tissue structure. You're going to end up with a slight refractile change in how the ultrasound beam is portrayed here. So it's less attenuated superficially, and it may cast a darker version of the image, versus here we have this really nice fluid-filled deltoid, which is also enhancing the underlying tendon relative to what happens underneath the deltoid septation. Also here in the posterior deltoid muscle may enhance the tendon. So if you see a dark shadow there, just do a couple internal-external rotations. It may clear up any of the shadow in the tendon. You don't want to call this little margin of the tendon tendinosis, for example. Here's our transducer location. Basically, you're going to palpate right under that posterior lateral corner of the acromion. And then I instruct people just to aim the beam into the joint. If you're already doing joint injections, just pretend the ultrasound beam is the trajectory of your scope or your needle, and you should be able to land an image like this. When we go to live scan, I'll show you the way to get an image really, really nice with the bones laying flat with our ultrasound beam. But this is a good dynamic maneuver when you're trying to evaluate for joint effusions. When you externally rotate, that capsule will unfold. Whether it's filled with fluid or not, you're still going to see this little capsule unfold, and it's very nice. So internal external rotations will help you delineate these tissue margins. Also on external rotation, there's a vein that dilates, and we'll cover that in the live scan. Going to short axis, pretend this animation has flipped to a short axis of the tendon following these panes that have been superimposed over the animation. And the extreme proximal, more proximal than that posterior lateral corner of the acromion, we see this central tendon of the infraspinatus is not yet formed to the more dense solid tendon. So it's still kind of surrounded by its multipinnate structure of the muscle overlying the body of the scapula over the infraspinatus fossa, which is outlined here. This is the inferior glenoid, and we'll talk about that when we get to the teres minor, but it is a great landmark for you to look at the muscle belly. As we travel distally towards the humeral head, you will start to see a more dense central tendon and perhaps some cartilage here, and then you're going to get a lot of shadow from the acromion, and we're going to do some maneuvers in the live scan to get rid of those. And then distally, it's a frustrating view sometimes if you're not going to move the shoulder, but you're going to catch the enthesis of the tendon here over that middle facet of the greater tuberosity, and a lot of it may be overshadowed by the acromion. So we're going to want to raise the elbow up and drop that humeral head down a little bit, and we'll do that when we scan live. Long axis, switching this way, we're going to the teres minor now. You're going to follow that humeral head inferiorly. Remember when we were scanning the anterior shoulder specifically, when I told you every time you translate the transducer down, because we're scanning the surface of a ball, you have to aim the handle down as well, which directs the beam up so that you stay 90 degrees to the surface of the bone. So we're trying to stay 90 degrees to the surface of the cortex of the humeral head and its inferior facet here. And whether you're internally or externally rotated will get you the difference between these two images here. So internal rotation, you get this really nice feather-shaped muscle. For a joint injection, for example, this is a great place to land your needle, not under the infraspinatus because of that real hard pop that you would get with that large central tendon. So if you could find that deltoid, or not the deltoid, if you could find the muscle bellies of either the teres minor or the inferior muscle belly of the infraspinatus, your needle will slip right through the muscle easier without that hard pop. And because we're using ultrasound guidance, the need for loss of resistance technique in injection is much less. But we're just taking a look at the very much more inferior teres minor here in long axis, and then we'll switch over to short axis. These are numbered out of order on purpose. The short axis view can be kind of frustrating for a lot of people at first. So can the long axis view, honestly. But if either view is difficult for you, what I would instruct you to do is just find that posterior humeral head-neck junction here, just like a hip. And this will be your cortical landmark. And there at that posterior margin, you're going to see the teres minor here sitting in that head-neck junction, just like you would in a hip if this were the joint capsule or something like that. Here we have the deltoid overlying this, and then up here is the infraspinatus, most inferior margin. And then from there, you just want to go translate the entire transducer either towards the scapula, which you'll catch the inferior margin of the glenoid here, and then come back to your home base of the humeral head-neck junction posteriorly, and then slide laterally to catch that inferior facet. So here we are at the enthesis of the teres minor, and highlighted I've got the muscle belly of the teres minor, the distal muscle belly of the teres minor here at our kind of landmark centrally, and then the tendon of the teres minor, most distal and lateral. And remember, we're scanning the surface of a curved object, so you want to stay 90 degrees to the cortical landmark here. But the triceps tendon makes a really, really nice landmark as it inserts. This is the long head of the triceps. It inserts to the inferior glenoid as well. It'll kind of hold the shape up of the teres minor. Let me go back one slide. No, or not. All right, well, let's just go to the live demonstration. I couldn't get my slide to go back, and we'll just cover those two tendons plus the posterior glenohumeral joint, as well as the spinoglenoid notch. So just a second while we get things transitioned over. All right, so now we'll move to the live scan, and today we're going to be scanning on the newly released Sonosite PX. I'll be starting with the L15 to 4 megahertz transducer, which is the overall general musculoskeletal exam probe. And then for some of your patients to get a little bit larger than I would say like my shoulder, you may want to opt to the curvilinear for the posterior shoulder, especially in injections. This is a curved 5 to 1 megahertz transducer. So if there's time at the end, we will switch over to that. But for now, I just want to point out my most frequently used palpable landmark, which you should always start with a skeletal reference point if you can. This is that posterior lateral corner of the acromion process, and I just want you to reach back here on your own shoulder and feel for that little bony prominence, because we're going to use it for the majority of this exam. What I like to do, and I'm going to keep screen left medial for this exam, what I like to do is palpate that bony landmark, set the upper part of the probe, this surface in long axis across that lower edge of the acromion. So I'm actually physically bumping that up against the acromion. So I'm just going to set the transducer down right here. And then if you're already doing injections in a shoulder, the direction of your beam will be relatively exactly like you do a glenohumeral joint injection. If you're not familiar with this anatomy, on the anterior part of the shoulder is the coracoid process, and you can feel that with your finger right up here, and you'll basically point your beam towards the coracoid. But the upper margin of the transducer is just rested against the inferior margin of that posterior lateral acromion point, this little prominence on the back. And then I'm just going to rest the palm of my hand on the top of the shoulder so I can scan comfortably. What we should see, and without even looking at the screen, I was able to see all of this, or I expected to see all of this, was the humeral head first. Let's pull the arrow up. So cortical landmarks are key. If you get a blurry image like this, and you see what vaguely looks like a bone down there, you're going to tilt the transducer until you get a nice, sharp, hyperechoic bony cortex. In this case, it's the humeral head, articular hyaline cartilage, and then this little white area here is the joint capsule. I'm going to follow the cortical landmark deep until we can't see it anymore, and I'm going to bring my depth down just a click or two. There. And then point out the next cortical landmark that we rely on, which will be the posterior glenoid tubercle here. So this is the posterior glenoid tubercle. And then back here, if we keep following this slope, is the infraspinatus fossa of the scapula. And then above this is infraspinatus muscle and central tendon, one of the pinnate directions of the central tendon. We'll get to the rest of the tendon momentarily. So between the humeral head and the posterior glenoid tubercle, we have this labrum here. This triangular fibrocartilage of the labrum is shown really nicely on ultrasound, just in the posterior shoulder. Don't rely on ultrasound for anterior labrum. Don't rely on ultrasound for inferior or superior labrum. But posteriorly, if you see some pathology back here, you're probably not far off whatever the diagnosis is leading to. If you suspect labral pathology back here and you do maneuvers and everything looks normal, but the patient's clinical presentation is that they may have some sort of instability, or if your clinical exam is pointing to labral pathology, don't rule it out with ultrasound. You still need to rely on a standard MRI for labrum. With that said, we will continue to examine what we can see back here, and what we're going to watch now is how to evaluate for a joint effusion of the posterior shoulder. If we don't already see a protruding joint effusion coming out from under the joint capsule here and spilling out posteriorly, let's see if we can cause one by doing a dynamic maneuver. And what I'm going to have our patient do is just slowly externally rotate, and we're going to watch that most posterior middle facet of the infraspinatus attachment come back here and almost bump against the labrum. And then here's our labrum. We've changed some densities there, and it's not as nice because the overlying infraspinatus is not really shining over the labrum. So I'm just going to bump my gain up in the far field. There we go. And then let's point out what we're seeing here. So the labrum is now this blunted edge instead of that sharp triangle. And then just above that blunted edge, here's the capsule that has redundantly folded posterior and more medial here. So I'm pointing at the capsule's interface. This is the central tendon of the infraspinatus. We have gone into external rotation, which has brought the enthesis posterior. So this is the anatomical position. If you're looking at an anatomy poster or book, when we're in external rotation, we expect to see the infraspinatus back here. Thing is, when we do these exams, typically the patient is in a relatively neutral position. So let's watch where the infraspinatus goes. I'm going to get off track here. And we're going to chase, and I'm going to rotate our shoulder for the camera here. That way we can chase this probe direction down all the way anterior, and we're actually just following the enthesis of the infraspinatus so that you get a general sense of just how anterior it goes. Remember, it's the neighbor of the supraspinatus, right? So here I am on the most anterior part of the lateral shoulder, as we did in our lateral shoulder webinar, and you can see that the infraspinatus looks a lot like a supraspinatus, except it doesn't have that inflection point of the greater tuberosity anteriorly. If I were to keep going anterior, you'll see supraspinatus has this inflection point on the greater tuberosity. As I go posterior, you'll see the greater tuberosity flatten out. We get a lot more acromion in the shot because the infraspinatus is going to dive under it. Now let's follow the infraspinatus central tendon posteriorly now until it's there laying over the joint here. I don't see it laying over the joint very well, which is okay. Sometimes you can just have the patient grab their opposite shoulder, and that will cause the infraspinatus and the humeral head to inferiorly drop. So there I do see that central tendon really nicely, and it makes it easier to evaluate the long axis of the infraspinatus tendon. So counting our layers underneath here, we've got glenoid, humeral head, here's that posterior labrum, and then let's watch this joint capsule under the infraspinatus kind of unfold itself. I'm going to keep our patient's elbow down to her side here, and then she's just going to slowly externally rotate, and let's watch this joint capsule unfold. Here we go, right there. And then let's internally rotate. Okay, and then it's folded and tightening over the articular hyaline cartilage of the humerus. Now let's externally rotate again. And this is where I'm looking for debris, calcium deposits to pop out of there, loose bodies, all kinds of things can just be shoved into this joint recess. But you can see that little fold right here, and it's a normal joint. And then internally rotate. That's where we would see a big joint effusion. And then just relax. Good. After our long axis plus that dynamic evaluation, I typically switch over to a short axis evaluation of the posterior infraspinatus. And by just going over the scapula here, that infraspinatus fossa, I think it's the easiest to obtain the short axis image. So I'm just going to go transverse, and I have the left side of the screen facing superior up towards the spine of the scapula, which is here. So here's the spine of the scapula on the most upper screen left, and you can see where the infraspinatus begins right here, this whole corner. We're just going to follow it down all the way to here, and then that's that inferior glenoid right there. So that's about where you would stop visually evaluating infraspinatus. So all of this is infraspinatus. It's a multi-pinnate, kind of a tripinnate muscle. So we see three different heads here very distinctly. Then the central tendon is still forming here. So it kind of looks like a tree. I've always kind of told myself it looks like a tree top here. The more proximal you go, and then the more lateral you go, it tapers together and becomes that central tendon. A lot of times it gets caught under the acromion shadow and you can't see it. That's when we have our patient reach up and grab the opposite shoulder there, and you actually saw the infraspinatus roll out from under the acromion. And then I'm going to adjust my depth. Here we go. And then let's just follow that anterior edge here. You can see the leading edge of the infraspinatus before it makes its way to the supraspinatus in this case. So I'm just following that, looking for involved tears that may involve infraspinatus and supraspinatus. Typically, you don't normally see an isolated infraspinatus tear, although I've seen a couple. It's just pretty rare to see just an infraspinatus tear. They're usually involved with supraspinatus as well. So let's follow this transverse infraspinatus posteriorly again and just check our work and go all the way down to its proximal musculotendinous junction. Drop my depth just a few clicks, and then here's that central tendon again. And I'm looking for atrophy of either of these muscle heads, any of these three groups. I need to see hypoechoic muscle out to this outer rim of fascia around the muscle. I don't want to see a grainy, thickened appearance around the muscle that would indicate some sort of fatty atrophy. Same with the supraspinatus exam. You would want to compare this muscle belly, for example, either with the teres minor, which we're about to segue into, or you can climb up north on the shoulder and compare the infraspinatus muscle belly to the supraspinatus muscle belly and make sure they look similar in echotexture. So here's our spine of the scapula now, and then here's our clavicle anteriorly. Okay, and now we see the trapezium superficially and the supraspinatus muscle deep. And I need that supraspinatus muscle to also look like the infraspinatus. It needs to have a nice hypoechoic echogenic appearance all the way out to this fascia, and then I'm just going to fall over that spine of the scapula posteriorly and compare its texture and thickness to the infraspinatus. So carry that into your clinical exam if you're curious about fatty atrophy. Fatty atrophy will look like a grainy rind around this cross section of the muscle, and you'll almost see the outer edge of the muscle taper in and look exactly like this tendon. So there won't be this hypoechoic normal gap of muscle, for example. I'm going to use this view to get us down to the teres minor. So the way I like to show people to do teres minor, because this can be a bit confusing, is go ahead and relax the shoulder. Good. And once we're over that humeral head, then follow the humeral head to the head-neck junction, kind of like you would a hip. So when we did the anterior hip webinar, we had a landmark of the head-neck junction for a hip injection. In this case, you're going to get a very similar view, and that's going to be for isolating and locating the teres minor, so that it's easy for you to compare. So here's that humeral head, neck. This is all teres minor here, muscle belly. Okay. And then right here is the central tendon. It's a bit superficial compared to the infraspinatus, for example. And what I'm going to do now is, just like in the PowerPoint, this being my home base view, I'm going to go laterally to its insertion on the inferior facet. There, you can see it not up above my arrow. That's still some infraspinatus involvement. This is the facet that I'm talking about. This is the teres minor. You can even see those little musculotendinous slips, or the little interdigitated slips, kind of like we see in a subscap. I don't know if that's going to be real easy to see on Zoom, but what I can do is zoom in on that so that you can see the detail of those little tendon bundles there. So here we see very nicely individual little heads of the teres minor right there. So I'm going to unzoom. I'm going to back out. Now let's follow proximally until we see another bony landmark. Remember, I'm scanning the surface of a cylinder in this case instead of a round ball. And as I go posteriorly, I have to aim back into the cylinder, right? So that's the scanning technique I'm applying here. Still following this muscle belly. Make sure it stays 90 degrees to your beam. It's nice and bright the whole time. There we go. Our next skeletal reference point just went down in depth a click, and bringing up the arrow is the inferior glenoid. So at this point, the inferior glenoid tubercle is the insertion of the long head of the triceps. This makes a really pretty view. So here's the triceps. This is the muscle belly of the teres minor. And you can see a little edge artifact casting a shadow here. And then coincidentally, just posterior to that, or inferior to that, is that this is the quadrangular space on this side of the triceps here, where you've got a little axillary nerve impingement that could happen back here, plus the circumflex humeral artery that goes posterior as well. And then we could follow that triangle more lateral to the humerus, where we get the quadrilateral space here. So humerus side of the triceps, quadrilateral space. Medial side of the triceps, quadrangular space. And using the triceps and the teres minor as a border to do that evaluation is really nice. So Why do we take this image here? So this is your evaluation image of the teres minor and the infraspinatus in the same shot. With this larger linear footprint transducer, it's 50 millimeters. We're able to capture, for the most part, the entirety of the infraspinatus muscle belly and the teres minor muscle belly in one shot. And we want to say, or be able to say, that the teres minor is approximately 1/3 the size of the infraspinatus. If the infraspinatus and teres minor are the same size, you really need to be looking at why is there either hypertrophy of the teres minor or atrophy of the infraspinatus. All right, so we've done the short axis of the teres minor. I'm going to go back to that head-neck junction view, and I'm going to rotate the left side of the screen medial, and we'll go over the scanning tips for the long axis of the teres minor. So there's our enthesis of the teres minor right here on that inferior facet. There, we can see its enthesis really nice here. And as I go more proximal, if I don't see a nice bony backboard of a landmark down here, what you want to do, because we're scanning, now we're on the ball of the humeral head, right? You're going to want to drop the transducer inferiorly and aim up, because we're scanning the surface of a ball. Remember, we need to aim up into the ball, and the goal here is to pinch that teres minor tendon between your transducer and the humeral head. That way we have a skeletal reference point in the image. So by doing this really sharp angulation upward, here, move my big hand out of the way for the camera, we can see the central tendon really nicely. We can see the posterior glenohumeral joint, and we have a nice skeletal reference point to follow. So I'm going to have our patient just slowly externally rotate, and that brings the enthesis of the teres minor. And let's just hold that position, and I'll point it out. Let's internally rotate just a bit more. Let's follow that enthesis here. Here's your enthesis. And then internally rotate a little more, right about there. And we can get both the glenohumeral inferiorly with the labrum and the teres minor all in that one shot. But look at the extreme acute angle I'm having to take to get that. You don't want to just follow the skin surface for this, or you might get a little lost in the soft tissue. You really do need to angle up to get that really nice glenohumeral joint. And let's internally rotate again. And there's our muscle belly with central tendon going proximally. And then lastly, following that glenoid tubercle, posterior glenoid tubercle, more proximally, let's look at the spinoglenoid notch, which I should have covered in the normal glenohumeral exam earlier. Here's our humeral head, posterior glenoid tubercle, and our infraspinatus fossa. If you're looking for the spinoglenoid notch like you saw in the PowerPoint, the only trick here that I recommend people do is plant the lateral side of the probe, and then you're going to pivot the medial side of the probe up north towards the scapular spine. So I'm just going to set my finger here as a pivot, and I'm just going to aim north. When I do that, I deepen that spinoglenoid notch, and then we can see, move the arrow, here's what we're looking at. This divot here, this is spinoglenoid notch. So just as a review, we have humeral head, posterior glenoid labrum, posterior glenoid tubercle, and now we're in the spinoglenoid notch, which is holding our suprascapular nerve posteriorly. There's also an artery and a vein down in there. And just to show the vein, what I'm going to have our model do is just slowly externally rotate, and you're going to see this vein dilate here. So that's normal. Go ahead and relax. If they're already in an external rotation, let's say go ahead and externally rotate and just hold it, and you're doing this exam, and you fall into that spinoglenoid notch, don't call this big hypoechoic structure a cyst. This is not a paralabral cyst at this point. It's just that dilated vein. And certainly don't throw a needle in there. Go ahead and relax, and you'll see that vein collapse. So just know that that is where we're looking for the posterior suprascapular nerve back here. There are those other neurovascular structures in the area too. So if I were looking for a paralabral cyst, sometimes they dump from the 9 o'clock labrum back here, but for the most part, from what I understand, they also can happen in the superior labrum and drop down into this notch. So you may not see the stalk of the cyst back here, It may be that this is a superior labral tear that has dumped its cyst down this notch, so that cyst can just pool down there, instead of it being something that you see originating from this part of the labrum. So if you do see a cyst there but you can't find the tail, obviously you're going to need to have an MRI anyways to see the extent of the labral tear, but that is what you should be aware of also. That is the posterior shoulder from a rotator cuff in standard evaluation minus the axillary nerve involvement back there in the quadrilateral space and quadrangular space. But from reviewing the infraspinatus tendon as a rotator cuff structure and the teres minor as a rotator cuff structure, those are the standard things to look for. I would say the teres minor is very forgotten in the shoulder exam. Almost nobody looks at it. So if it's not a part of your normal protocol, I would say it's normal for it not to be a part of your normal protocol. But don't forget about it, because sometimes you do need to measure it against the infraspinatus. And it is a requirement in the AIUM protocol for shoulder exam. So you shouldn't skip it. You should at least get the two views, long and short axis of the teres minor, as a part of your routine shoulder exam. But that will conclude today's webinar on the posterior shoulder. If you have any questions, go ahead and just type those in the chat portal while we're waiting on those questions. Don't forget, next webinar is over the superior shoulder, where we're going to cover AC joint, some dynamic maneuvers here, and some other surrounding structures after the basic shoulder exam of the AC joint and its dynamic maneuvers. We'll also cover some of the surrounding muscles and nerves and answer your questions live like we always do.
Yeah, Daniel, you read my mind. I was just about to say we have about 2-3 minutes left. So if anyone has any questions, feel free to enter them in the Q&A box.
Incidentally, here we are at the quadrilateral space and the quadrangular space for your overhead throwers. This is a great entrapment neuropathy of the axillary nerve and that posterior circumflex humeral artery right in here. You can throw your color on. Anybody dealing with sports injuries and diagnoses and any other differentials in the area, this is a great use of your color power Doppler or your directional color Doppler here. So landmarks for that we didn't cover in the PowerPoint because it's not a normal protocol.
We did have a question.
Oh. Okay, cool.
We have a question. Just says, at that moment, I noticed you went deep. What is the ideal depth?
So our machine with this transducer, the PX with the L15 transducer, is going to boot up at 2.7 centimeters, 2.8 centimeters, okay? So on a normal size shoulder, somebody that's lean and fit, that's going to get you there for just about everything, right? Once the shoulders, and not to be insulting to people, I say once they get bigger than my shoulder, you may want to switch over to a curvilinear probe when you go past 4 or 5 centimeters. Then they start to get a little deep and a little hard and out of reach for a linear array transducer. But I would say in most cases for the posterior shoulder, you're going to be around 3 or 4 centimeters to see the structures that you need to see with confidence. At boot up, you can see most of the shoulder here at 1 inch. And I was once told that you can just about reach everything on the extremities with a 1 inch needle. So you should be able to scan just about anything at 1 inch until the body habitus starts to get a little bit deeper. But Spinoglenoid notch, for example, is 3 centimeters. You can see the centimeter hash marks on the right side of the scanning image. If you're not seeing those, let me pop my trusty arrow up. This is 3 centimeters. So in this patient here today, the spinoglenoid notch is roughly 3 centimeters deep. That may need to change. I may need to switch over to a curvilinear on some people. Okay. And having one of those handy really makes sure that you are not limited in any scanning that you do in MSK. So I'm going to switch over to the curvilinear. This is the C5-1. It's capable of penetrating to 30 centimeters, which is never necessary. But if you're scanning hips, large shoulders, spine, anything in the adductor region or hamstrings, piriformis, things like that, the curvilinear is really, really nice. Let me gain up for zoom. There we go. And then I'm going to hit audit. Well, no, I kind of like that. Good on my end. It's a little hot on the Zoom side, so let me just soften that up just a touch. There we go. So different looking image, much more penetration. For example, I think I can probably drop underneath the glenohumeral and probably hit her chest wall and ribs posteriorly very easily. Those are rib shadows.
Wow.
Way down at the bottom of the image.
Yeah.
Here, and then this is sliding along, pleura, another rib.
That's impressive.
Rib. Isn't that cool?
Yeah, very
I
cool.
think that just about every time we scan something new. So, anyways, have a curvilinear handy. If you're seeing shoulders bigger than mine, have a curvilinear handy. You'll really thank yourself.
Okay, I know we're really short on time, and we did have a couple of questions pop in, so let's see if I can get through all of these.
Yeah, we got 5 minutes.
Okay, 5 minutes, good. In short axis view of the teres minor, can you show the upper tendon, what it looks like in the longitudinal view?
You bet. We'll switch back to the linear. Very easy on the PX. And I'm just going to jump right down, angle up, because you should have good scanning habits after doing this a few times of just being able to drop on these. But here we are in long axis, and let's go to the most distal insertion first, okay? If you've ever scanned a knee, the pes complex looks a lot like this too. So here's our arrow. This is the enthesis right here of the tendon. And now let's follow that enthesis proximally, and then you'll see how shallow the tendon is relative to the rest of the muscle. It stays right up on this top surface of the rest of the muscle. Here we go.
Okay.
Hopefully that helps, but
yeah, there's
is a lot more in depth to scan. The teres minor is just thinner.
Right. Can you repeat the quadriceps space scan?
Yeah, there's a quadrilateral window here where the axillary nerve outpouches from the axilla. And you want to follow that. This is where the teres minor actually is. Really, really fun to learn how to scan. So here's our humeral head, neck, follow the neck down. And then this is the quadrilateral corner or space right here under the teres minor belly, muscle belly. So here it is where we have that circumflex humeral, that posterior branch, that artery right there. And then once we pass the triceps medially towards the spine, we change names to the quadrangular space. So here's our triceps. Mm-hmm. Here. And then this little wedge up here is your quadrangular space. So it just kind of changes names at that point. And then I'm going to pass the triceps laterally and fall into the quadrilateral space right here.
Okay.
Artery is your best friend at this point. Have good color.
Here's another question. Do we look at the latissimus dorsi like we check the pec major and the anterior shoulder?
I see people make that a part of their some of their anterior protocol, even because that latissimus is going to go curl anteriorly underneath that pec major. So it's not a part of a normal protocol at all, but people do scan it. I'd rather scan that with a little anatomy review ahead of time, but it is a great question, maybe for a miscellaneous shoulder talk. If that's something that you would like, email Laura and we'll cover the random stuff like we're getting into now about latissimus, the quadrangular space, triceps, which is not a part of the shoulder protocol, but it makes great landmarks. Mm-hmm. Other pathologies like that can be evaluated in the shoulder.
Yeah, definitely.
Today go ahead, Laura.
I'm sorry, Daniel. Definitely email me if that's something you guys would like, because we can definitely put together a webinar that's just more of a Q&A for, the miscellaneous areas of the shoulder. And then last question is, how accurate is scanning for scapular winging with MSK? Winging.
I've never really done that. So I'll have to ask one of our sports specialists that we have on staff. We have a couple of athletic trainers, for example. That would be another really good one, I think.
Okay.
But I've never scanned for the scapular winging. So give me something to study for. Or I'll just go to our athletic training experts that we have on staff and maybe have them as a guest, and maybe we can cover some of those more dynamics that are not a part of a rotator cuff protocol.
Okay, that sounds great too. I'll definitely keep that name on hand, and we can get back to that person after the webinar.
Cool. Okay, great.
Great. Well, with that all being said, I'm going to share my screen really quickly here. So for future webinars, please check out this website. It is Behind the Scan, sonosite.com/behind the scan for upcoming topics. We do have superior shoulder coming up on June 1st at the same time. Thank you everyone for joining us today. That concludes our webinar today. We look forward to seeing you at future webinars soon. Thank you.